Hello and welcome to Living with Parkinson's, your emotional and social wellness. I'm Ashley Choi, Community Program Manager for the Great Lakes chapter of the Parkinson's Foundation, proudly serving Ohio, Michigan, and Western Pennsylvania. We want to warmly welcome any of you who are joining us for the very first time and take a moment to share the mission of the Parkinson's Foundation. The Parkinson's Foundation makes life better for people with Parkinson's disease by improving care and advancing research toward a cure. And in everything we do, we build on the energy, experience, and the passion of our global Parkinson's community. To achieve our missions, we pursue three goals. First, improve care for everyone with Parkinson's. Second, advance research toward a cure. And lastly, empower and educate our global community. We provide free resources, including educational books, webinars, podcasts, and a life-saving hospitalization kit, and our toll-free helpline staffed by Parkinson's specialists. I want to highlight our national initiative, PD Generation, that offers genetic testing and counseling at no cost to anyone diagnosed with Parkinson's disease. You can participate in person at a Parkinson's Foundation Center of Excellence near you, or with an at-home cheek swabs and telemedicine appointments. For more information about PD Generation, please visit parkinson.org/pdgeneration. We have also started a new initiative meant to capture the community's perspective on various topics over Parkinson's disease, like mental health, telehealth, and cannabis. By signing up for this initiative, we will email you up to 4 times a year, requesting that you complete a 10 to 20-minute survey. We will always report findings back to the community and encourage you to visit the link on your screen for more details. I would like to now acknowledge our chapter supporters. Our gold sponsor for today is Abby. Thank you so much to Abby for making today's program possible. We greatly appreciate your generosity. Our next chapter supporter is Kyokurin as a silver sponsor. Many thanks to Kyokurin for your support. And last, our thanks to our bronze sponsor, Amnio, for your support of today's programming. Please visit this link to learn more about what AbbVie, Kyokurin, and Amnio are working on for the Parkinson's community. Now it is my great pleasure to introduce our very first speaker. Dr. Merola is the director of the Center for Parkinson's Disease and Other Movement Disorders at the Ohio State University. He co-chairs the International Movement Disorder Society, MDS, Tremor Study Group, and the Parkinson's Study Group, PSG, Motor Features of Parkinson's Disease Working Group. He's also the member of the MDS Task Force for Early Onset Parkinson's Disease and the MDS Task Force for Technology in Parkinson's Disease, the Italian Scientist of Scholars in North America. Dr. Merola is the author of over 100 peer-reviewed scientific publications in international medical journals and the principal investigator for multiple clinical trials. His primary areas of interest involve clinical neurophysiology, gait analysis, kinematic analysis, electromyography, cardiovascular autonomic testing, gene therapy, deep brain stimulation, infusion therapies, and MRI-guided focused ultrasound. Dr. Merola, please go ahead and start your presentation.
Thank you, Ashley, for the very kind presentation. And thank you all for being here today in this great event that has been organized by the Parkinson Foundation. It is my total pleasure being here and to discuss a little bit more about the cognitive symptoms that can be observed in Parkinson's disease, and specifically how these can affect the emotional and the social wellness. So we can move to the next slide. Real quick, those are my disclosures, none of which is really related to the topic discussed in this presentation. And going to the next slide, and jumping into the main topic about today's presentation, we're going to cover what neuropsychiatric symptoms can be observed in Parkinson's disease. So when thinking about Parkinson, everybody immediately think about the motor symptoms, which means the tremor or the slowness of movements or the rigidity. But the truth is that non-motor symptoms, and specifically neuropsychiatric symptoms, can actually be even more disabling. But frequently these symptoms are overlooked, and frequently we don't even talk too much about that during our visits. So today wants to be a moment in which we go a little bit more into what are the symptoms, how they can affect people living with Parkinson, and what can be done and what should be reported during the clinical evaluation. Specifically, when looking into Parkinson's disease, there are 5 key symptoms that are observed in almost 30–50% of people living with Parkinson. Depression is for sure the most important and frequently associated with anxiety. And this can be observed since the very beginning of the disease onset. Sometimes actually depression can even precede the onset of Parkinson. Then later we can have psychosis, which means hallucinations or mild delusions. And this is something that is more frequently observed when the disease progresses and can be partly related to medications, we'll discuss that, or partly just related to the disease itself. And then we have 2 other main symptoms, which are cognitive impairment or dementia and impulsivity. And again, we're going to go into this and we're going to discuss the little nuances in how to recognize the symptom and how to try to manage that. So next slide, please. So let's start about depression. There are a couple of points I want to point out about depression in Parkinson. The first one is that depression affects up to 17–22% of people living with Parkinson. And still, this estimate, which basically means 1 patient out of 5, is still probably underdiagnosed. My personal impression is that depression can affect more than 20% of people living with Parkinson. Something that is very important to point out is that depression does not necessarily appear as a consequence of the diagnosis. So people living with Parkinson, it's not that they develop depression because they got the diagnosis of Parkinson and they may have struggling in dealing with the diagnosis. Because depression actually frequently starts even before the onset of Parkinson. It's not uncommon to see patients that in their mid-50s, they start having a depression, and 1 or 2 or 3 years later are actually diagnosed with Parkinson's disease. And this is telling us a lot about the fact that depression is not a reactive depression, is not a consequence of a problem in coping with the diagnosis, but it's rather a very intimate part of the disease. This is not surprising because when we know that Parkinson is related to lack of dopamine, we also know that dopamine is involved in motivation. So the lack of dopamine does not necessarily mean difficulties in moving, shuffling, slowness, tremor, but also means lack of motivation. And that's exactly the type of depression that we see in people living with Parkinson. It's what we call an anhedonic depression, which means a sort of losing the joyness and the happiness of living an everyday moment of life. And so this is a different depression for the depression that is seen in the psychiatric context. It's more associated with anxiety, and it's more associated not really with feeling depressed, but more like not being able to fully savor and enjoy life. Let's go to the next slide. So multiple studies have been done to better understand where this depression comes from and also to understand how we can treat that. And what we see here is a relatively old, this study was done 15 years ago, but still remain one of the main studies in the field that clearly showed using advanced magnetic resonance imaging, this is called functional magnetic resonance imaging, clearly showed that specific areas of the brain are the areas that are involved in patients with Parkinson reporting depression. And specifically, there are three different areas: the locus coeruleus, the thalamus, and the amygdala. Now, the locus coeruleus is one little area that is located deep into the brain that produces serotonin, which is an important neurotransmitter for motivation and well-being. So, in other words, the same process that affects the production of dopamine also affects the production of other neurotransmitters. And these other neurotransmitters are the real responsible for the depression in Parkinson. Next slide, please. Now, when talking about depression, especially in a clinical setting, sometimes it is difficult to differentiate what is depression from what is anxiety. So the proper definition for depression is a sort of not being able to enjoy life, feeling hopeless, or losing interest in several activities. Anxiety frequently gets along with depression, so they are a combination of the two, but it's still something different. Anxiety is more the feeling of being overwhelmed by problems and being over anxious about the fact of not being able to deal with some difficulties or problems, or being over anxious about things that in other phases of our life we will be able to, to deal better with. Anxiety in Parkinson can also be triggered by very good reasons. For instance, what happens if I go outside and then the medications wear off and I have trouble moving around? What happens? Am I going to feel embarrassed if for some reason the medication wears off? Or even the anticipatory anxiety of what's going to happen during the day, because we know that there might be fluctuations, and these fluctuations are sometimes associated also with discomfort, with pain. Or maybe even feeling overwhelmed by the idea that going out, maybe to a restaurant or enjoying a quality time with friends and family, maybe some tremor is going to come up. Maybe this tremor can be a source for embarrassment. So, in other words, what I want to say is that while depression seems to be something very organic, very related to the very basic mechanisms that cause Parkinson, frequently anxiety is a sort of a combination that has both aspects, both a lack of neurotransmitters, but also feeling, anxious towards some of the aspects that are related to the challenges that Parkinson can pose. Now, it's interesting to think about, okay, so we are aware about these problems, but the first step is discuss this problem, report these problems. And the second step, of course, is being proactive of how can we treat that. Sometimes our patients don't want to report these problems because they're worried about, getting medications, and maybe they don't want to take other pills, or they're worried about, they feel embarrassed about that. So two messages. The first one is there's nothing to be embarrassed of. These symptoms are frequent. They happen in more than 20% of people living with Parkinson. And the second message, please report that, because we do have multiple strategies for dealing with that. Of course, there might be medications. They may be a good fit for a certain portion of patients, but there is also psychotherapy. There is also cognitive rehabilitation. There is also different strategies that can be used. But even the fact of bringing this out frequently, helps us realizing that maybe it's not as bad as we were thinking of. Maybe talking about that could just be by itself helpful. So next slide, please. Now, let's jump into another important topic that I'm grateful I have the chance of clarifying. So what are hallucinations and why are they so frequent in people with Parkinson? So, of course, every time we hear the word hallucinations, we always think about something like a psychiatric disorder, somebody hearing voices. In Parkinson, it's not like that. Patients with Parkinson generally do not hear any voices. And the type of hallucinations they have, it's a very distinct and particular type of hallucination. And this is related to the fact of seeing objects that are not really there, or maybe misinterpreting certain objects. I will show you later a picture that can be used as an example of what can trigger hallucinations in Parkinson's disease. But frequently what happens is that seeing something that can be equivocal is usually misinterpreted by the brain of people living with Parkinson. And so maybe just a bunch of flowers can look like a face or can look like an animal. Or frequently in the periphery of our visual field, patients can see like cats or little animals moving around. Why this happens? And is this a serious thing? So why this happens is a combination of factors. Parkinson itself can predispose to hallucinations. The same area that is involved in Parkinson, it's very close to another area that is involved in this type of hallucinations. But on top of that, also the medications that we give for Parkinson, these medications contain dopamine, and dopamine works well for Parkinson, but can also facilitate this type of hallucinations. In particular, certain types of dopamine, which is called dopamine agonist. So it's not uncommon to see hallucinations in patients that are taking dopamine agonists, for instance, pramipexole, propinerol, or other medications like this, because they can facilitate a little bit these hallucinations. Other factors that can trigger hallucinations are other medications, for instance, the amantadine or 3-hexyphenadiol, or medications that are taken for urinary incontinence. These medications, again, can facilitate a little bit the onset of hallucinations. This is another important factor because if the medication is responsible for the hallucination, you have to report it. Because if you tell your doctor, the doctor can change the medication, can give you something like levodopa that generally causes fewer hallucinations. And so this problem can be an easy fix. But also we do have newer medications for dealing with hallucinations. So one important aspect is this, because I have many patients that tell me that they see commercials on the television speaking about hallucinations. And so they say, okay, so it's going to happen to everybody. It's going to happen to me. That's not true. So let's say that only 50% of patients with Parkinson at some point during the life are going to experience hallucinations, but the other 50% is not. So this is not going to happen to everybody. The second point, yes, there are commercials on TV, but everybody experiences hallucination in a different way. So it doesn't necessarily have to be exactly in the way in which the commercials is reporting that. Another point I want to discuss is the fact that there is one symptom that is frequently misunderstood as hallucinations, but is not. And this symptom is called RBD. I'm going to explain a little bit what that is. So people with Parkinson frequently, when sleeping at night, can have vivid dreams, vivid nightmares, during which they feel like the nightmare is very real. They can scream, punch, kick, And they can even punch somebody, the partner, in the bed or fall out of the bed. So this is not hallucinations. So when happening, this is something different that can be misunderstood as an hallucination, but is a sleep problem associated with Parkinson and not an hallucination. So it's important to discuss the symptoms with your doctor, because according to the symptom, the doctor can help you and guide you, and the treatments might be different. So let's go with the next slide, please. Yep, that's an example. I don't mean this picture to be disturbing to anybody, but I just want to point out what is an example of something that can be misunderstood. So this is a picture from some flowers in one patient with Parkinson, 74-year-old patient, said that he was seeing like a face of somebody into the bush. We can clearly understand why, because, you know, this picture is a little bit, I can even see something in there if I lose a little bit my attention. But this is an example of what can be the type of hallucinations that we see in Parkinson's. So there are more misperceptions, like overinterpreting something that is not really there, rather than really hearing voices or something like that. Let's go to the next slide, please. So we said before, why these hallucinations? And I told you before that there might be different factors. So the medications, so dopaminergic medications can be a factor. Cholinergic deficiency, again, what do we mean with cholinergic deficiency? We mean that sometimes we take medications for other purposes, for instance, for the bladder, oxybutynin, or for the dyskinesia, amantadine, or for the dystonia, 3-hexyphenadiol. And these medications are called anticholinergics. They work well on the symptoms they're supposed to work with, but they can facilitate hallucinations. A third point, everybody probably knows that Parkinson is sometimes associated with little changes in the retina, in the inner part of the eye. And these little changes sometimes can create problems in perceiving colors, different colors. And this misperception of the colors can be one cause for these misperceptions or hallucinations. We are about to start a study here at Ohio State with a special technique called OCT that allows looking into the retina. And looking into the retina, we believe that we can track the progression of the severity of Parkinson. This is also a way to say that alterations into the eyes are A, frequent in Parkinson, and B, can tell us a lot about different aspects of the disease. And of course, not resting well, being tired, having problems in the sleep rhythm, this can be one factor that can stimulate or facilitate hallucinations. Next, please. So what can we do when we have hallucinations? So just in one word, speak with your doctor. The doctor is probably going to recommend the following flow chart. Number one, rule out infections. Remember that infections, especially urinary tract infection or UTIs, are the first cause for hallucinations. I have many of my patients that don't drink too much, don't drink enough. And they don't drink enough because they are worried that maybe I have accidents. They're worried that, you know, if I drink too much, then later I have to go to the bathroom too frequently. But this is a big, big mistake, because getting dehydrated is the first cause for hallucinations and urinary tract infections, which can cause hallucinations and also other problems. But let's say that our patient is drinking, and that's not the problem. There are no infections. At that point, we look at the medications. Of course, if somebody is taking selegiline, 3-hexyphenadiol, amantadine, dopamine agonist, and another 35 pills every day, there might be a cause for hallucinations. So we need to take away some pills, simplify the regimen. And if the problems is still there, at that point, we have a pretty good medications to take care of the hallucinations. What I say every time is hallucinations is a problem that we can take care of. We can fix it. And so please report it, because if you have this problem, we can manage that. So is one of the problems of Parkinson that fortunately can be treated. Let's go to the next slide. So this is a study written by our colleagues from Chicago, Dr. Goas at Rush University of Chicago. And basically, they look into one point. They said, is there any advantage in treating hallucinations? So let's say that we have patient A that says, I have hallucinations and I want to treat it. And patient B who said, I have hallucinations, but I don't want to treat it. I can live with that. Is there any advantage in terms of quality of life, in terms of long-term disability progression? So at Rush in Chicago, they did this study and they came to the conclusion that yes, there is an advantage. Hallucinations should be treated because in the long term, treating hallucinations results in a better outcome. So even if patient B says, I have it, but they don't bother me, it's better to treat it. Let's go next. Now, I want to spend the last few words, a couple of slides, talking about this frequent problem, which is kind of unique about the Parkinson patients population. And this problem is called impulsivity or punding. So punding is a complex word. I'll try to explain what it means. Sometimes, fortunately, not too frequently, our patients with Parkinson, they have a tendency to repeat a certain motor task over and over and over. Task, for instance, like collecting stones or rocks or organizing and reorganizing over and over certain things in a way that is way more than actually is needed. So this behavior is called punding, and this is a particular behavior that has been associated with one specific type of medications taken by patients with Parkinson. And this type of medication is called dopamine agonist. So dopamine agonist, as we'll see also in the next slide, are medications that can definitely be useful in the treatment of Parkinson. However, sometimes it can cause side effects. Punding can be one of these side effects, and the other side effect could be impulsivity, so doing too much of something. This becomes a problem when it comes to gambling. So every time we prescribe this medication, we say, if you take this medication, please report if you feel like any impulse disorder in making too many phone calls or gambling or doing too much of anything. So this was described for the first time 15, 20 years ago. We have a few examples here just to contextualize this. The first case is an engineer who used to sort rock collection and collecting pieces of wood, which might be an innocent behavior, but if we look sometimes, we see that this is disproportionate, takes too much of the time. We have a patient 2 who is an electrician who was obsessed with photography, and he dismantled the 5 cameras, and he was dismantling and re-putting together and collecting music. Oh, the third patient dismantles radios, pens, videos, and clock. There was a repetitive paper shuffling or other repetitive behaviors. So this is something, again, that should be reported if you notice that in yourself or in one of your family members, because this is frequently a side effect of a medication and can be treated. Let's go to the next slide. And yes, punding is frequently associated with the impulse control disorder. So a sort of difficulty in handling and controlling the impulses. And this becomes particularly worrisome when it involves gambling, the financial situation. So usually men have a tendency to gamble. Women usually have a little bit more of a tendency to pathological shopping. So maybe it's okay buying a couple of shoes or purses, but when this becomes too much, it's too much. And we have to be, honest about that. And again, frequently just changing the medications can take care of this problem. Let's go to the next one. And yeah, that's what we were saying before. This is due to dopamine agonist, which creates this pathological behavior. I think this was my last slide. Let's see if there is something else next. And no, we have a beautiful picture of Clarisse, who is our nurse practitioner. And thank you so much for your attention. I very much look forward at the end to addressing your questions.
Thank you, Dr. Merola, for that informative presentation to show us some of the cognitive symptoms of Parkinson's that may be affecting people's wellness. Just a reminder for all of our audience, please keep submitting your question using the Q&A button, and we will answer them all together during the end of the moderated Q&A session. Our next speaker is Clarisse Goas. Clarisse graduated summa cum laude from with research distinction from the Ohio State University in 2008 with Bachelor's of Science in Psychology. She graduated in 2012 with her MSN in Adult Health after receiving the Health Resources and Service Administration Award. She worked for 4 years at Pickaway Health Services in Orient and Circleville in primary care. Her father was then diagnosed with Parkinson's disease, leading her to subspecialize in movement disorders. She worked for 4 years at Wake Forest Baptist Health in Winston-Salem, North Carolina, working with movement disorders patients. She returned home to Ohio in 2019, where she began to work at the Ohio State University Wexner Medical Center in the Advanced Therapies Clinic in January of 2020. She has experience in clinical trials, deep brain stimulation, and DOPA. Clarisse, please go ahead and start your presentation.
Thank you. Thank you for that kind introduction. And of course, it is always difficult to follow up Dr. Merola, but I am just going to speak just a little bit about everything that Dr. Merola talked about, but what does the advanced practice provider do for those folks with some cognitive symptoms in Parkinson's disease? So a lot of folks, when they first come to a movement disorder center, are very excited to see their physician. And then the next visit, they are going to see a nurse practitioner or a physician's assistant. And that can be a little intimidating. Patients have a lot of questions about what nurse practitioners and physician's assistants can do. And so I just wanted to clarify that. I'll just have a very short presentation to talk a little bit more about that. So next slide, please. So advanced practice providers are nurse practitioners or physician's assistants, specially trained in PD. It can also refer to physical therapists and things of that nature, but we're not talking about those today. So we have master's degrees, and then we also have subspecialty training on top of that. We often see patients pretty frequently in most practices. Physicians typically have other responsibilities outside of their clinical duties. So you likely will see the nurse practitioner or physician's assistants quite a bit. So we really want you to be comfortable with that. Next slide, please. So we are highly trained, and we are able to recognize and diagnose and treat cognitive symptoms of Parkinson's disease, as Dr. Merola so eloquently described in his presentation. So we can recognize, diagnose, and treat depression, anxiety, apathy, impulsivity, dementia, and psychosis. So just as the physicians can, we can also treat those conditions. Next slide, please. So, we'll give the same exams that your physician would give to assess your cognitive and mood symptoms. Sometimes they're just questions that we ask you. Sometimes there's a short, quote unquote, little test called a MOCA. Or something to that effect. We also can give you those medications that can treat those symptoms, and oftentimes we will titrate them for you. Sometimes the physicians will start them, and then we'll see you back more frequently until we've got the dosage just right. And sometimes we'll start those medications and continue to see you back until we get those medications just right and you're feeling much better. A lot of times I know here at Ohio State, we can conduct telehealth visits in between to discuss progress. Some of our patients come quite from far away, and with COVID, we've seen a lot more telehealth recently. So it's a lot easier for us to follow up on some of these symptoms. Some of our patients feel like it's, you know, a bit of a burden to keep coming back and forth when we need to make some of these medication tweaks more frequently, but it is a lot easier and a lot more palatable to do these via telehealth, whether it be a video or even just a phone call. Some of these things, if we don't necessarily need to lay eyes on you, we can even do them by phone calls. And then you're not waiting 3 to 6 months in between appointments for us to, you know, help with things like psychosis or anxiety or depression or other things of that nature. Of course, we also answer phone calls and MyChart messages, so we can do that just like the physicians can as well. Next slide, please. We can also refer patients, which we do a lot of. We work with a pretty big multidisciplinary team. So cognitive neurology, we can send folks who are having some more serious cognitive problems to see if there's any other treatments or studies that they might want to be involved in. Psychology, you know, counseling is often helpful for some of these things. And sometimes psychiatry. So if the medications get a little too advanced, or we just would love to have another set of eyes and see if maybe we're missing something or there's an easy change that we can make that can help, we might send you to a psychiatrist. And then social work, they're another great member of our team, and they can help often with arranging lots of different things for our patients in these situations, which can help quite a bit as well. So next slide, that might be my last slide. So again, very brief presentation, but in summary, advanced practice providers, we work with the multidisciplinary team, we work with your physicians, we work with the nurses and your physical therapists and your psychiatrists and social workers and everyone to really try to develop the best care plan for each individual patient and your cognitive symptoms. So we're always here. You know, it's nice to go back and forth, I think, between two providers. 2 sets of eyes are always better than one, and can just help a little bit, have a little bit more insight into your care and help make this Parkinson's journey just a little bit easier. So I believe that is my last slide, and I will be passing the torch on to my wonderful colleague, Dr. Boxley.
Thank you, Clarisse, for discussing the importance of having a multidisciplinary team in managing your Parkinson's symptom. Next, it's my pleasure to introduce our third speaker. Dr. Laura Boxley is the Director of Clinical Neuropsychology Training in the Department of Psychiatry and Behavioral Health at the Ohio State University Wexner Medical Center. She completed a doctorate in clinical psychology in Loma Linda University and her residency at the Veterans Health Administration Ann Arbor in the University of Michigan. Dr. Boxley's clinical and research interests include the cognitive and psychiatric correlates of medical illness, including neurodegenerative disease, movement disorders, and traumatic brain injury. Dr. Boxley, please go ahead and start your presentation.
Yeah, thank you so much for the introduction. I appreciate it. To start out, I have no disclosures, no financial conflicts of interest. Let me share my screen here a little bit. Okay. So as we heard from Dr. Merola, Parkinson's disease can be associated with changes in mood and behavior due to neurodegenerative change and functional change. We know that it is very important to treat symptoms of depression and anxiety because it can have a deleterious effect on quality of life and potentially length of life. For example, untreated depression is associated with deterioration in cognitive and motor functions and reduced overall quality of life. Also, individuals who struggle with both cognitive deficits and depression see the greatest decreases in their independence and their quality of life. So what are some common symptoms of depression among individuals with Parkinson's? The answer is that it's very similar to general depression, including feeling slowed down, restlessness, fatigue, changes in appetite, changes in sleep, feelings of worthlessness, and feeling that life may not be worth living. You might notice that there is some overlap between Parkinson's symptoms and depression symptoms, or maybe between depression and some symptoms of other health concerns you might have. Your healthcare providers are well positioned to look at these symptoms in the context of your overall health and comorbid conditions. The good news is that we have excellent therapeutic tools for managing depression, which I will touch on in just a moment. Similarly, anxiety can be associated with Parkinson's disease, particularly among individuals who are experiencing things like postural instability, gait dysfunction, on-off fluctuations, and functional decline. Anxiety can be clinically described in a number of ways. So generalized anxiety disorder is generalized anxiety associated with feelings of nervousness and recurring thoughts of worry and fear. This worrying is an excess of what would be normally expected given the situation and often leaves the person feeling out of control. Physical symptoms that may accompany these feelings include maybe nausea, trouble breathing or swallowing, racing of the heart, sweating, and increased tremors. Panic attacks are another symptom or experience of anxiety you may have. Usually they start suddenly with a sense of severe physical or emotional distress. Individuals may fear as if they cannot breathe or they're having a heart attack. They may feel that they're experiencing a medical emergency. These episodes usually last a few minutes to an hour, particularly when associated with the off periods, though they can last for longer periods of time. And then social avoidance. Dr. Merola kind of touched on this a bit in his presentation as well. Social avoidance or social anxiety disorder involves avoiding everyday social situations because of a fear of embarrassment. And having Parkinson's symptoms such as tremor or dyskinesias or trouble walking noticed in public. Exposure to social situations that can lead to severe anxiety in these individuals, which tends to go away when the person is removed from the situation or when they avoid the situation. Again, the good news is that we have excellent therapeutic tools for each of these anxiety conditions. So your healthcare provider may recommend medications, psychotherapy, or a combination of both treatments to address symptoms of depression and anxiety. Your treatment plan will be specific to your symptoms and medical history and is best determined through a collaboration between the patient and their care team. So I'm going to talk about a few of some of the more common therapies for individuals with Parkinson's disease, and some of you may already be familiar with some of them. So cognitive behavioral therapy, or CBT, generally focuses on specific problems using a goal-oriented approach. As you go through the therapy process, your therapist may ask you to do homework, activities, reading, or practices that build on what you learned during your regular therapy sessions. They'll likely encourage you to apply what you're learning to your day-to-day life. CBT is based on several core principles, including the idea that psychological difficulties are based in part on unhelpful or faulty ways of thinking. Psychological difficulties are based in part on learned patterns of unhelpful behavior that can be changed, and that people suffering from psychological problems can learn improved ways of coping with them and then lessen their symptom as a result, and become kind of more effective and productive in their life. CBT treatment usually involves efforts to change thinking patterns. So these strategies might include learning to recognize one's distortions in thinking that are creating problems and then to reevaluate them, gaining a better understanding of the behavior and the motivation of others, or using problem-solving skills to cope with difficult situations. CBT treatment also usually involves efforts to change patterns. So this might include learning to calm one's mind and to relax one's body in key situations, addressing the way one responds to fears and worries, or preparing for a potentially problematic interaction with others. Group therapy is another form of psychotherapy in which one or more therapists will treat a small group of clients together as a group. This type of therapy is available at a variety of settings. So you might see them in private practices, in hospitals, in mental health clinics, or in community centers. Group therapy is sometimes used alone, but can also be integrated into a comprehensive treatment plan that also includes individual therapy. In these groups, you may work on strategies common to cognitive behavioral therapy. Other group options could be psychoeducation groups or skills development groups or support groups. Groups can be as small as 3 or 4 people, but group therapies can be as big as 8 to 12 or more people. Most commonly, they may meet for an hour about once a week. Sessions can be open or closed. So an open session would mean that new participants are welcome at any time. A closed session might be a core group of members that are invited to participate, and additional members would form a secondary group. So what does a typical group therapy session look like? A session might begin with members of the group introducing themselves and sharing why they were in group therapy. Members might also share their experiences and progress since the last meeting. The precise manner in which the session is conducted depends largely on the goals of the group and on the therapist style. Some therapists might encourage a more free-form style of dialogue where each member participates as they see fit. And other therapists might have a specific plan for each session that might include having participants practice new skills with other members of the group. One of the unique benefits of group therapy for Parkinson's disease is that the group will contain individuals who share your lived experience. As much as your family and friends may sympathize and empathize with your experiences, there's something unique about talking with somebody who knows exactly what you're going through. Group members may also share solutions for common problems or ways of thinking that hadn't occurred to you yet. In my experience, group therapy can be very powerful in a way that is fundamentally different than in individual therapy. So compensatory strategies training involves working with the therapist to identify areas of relative cognitive vulnerability, and then developing personalized strategies for coping with them or working around them. One way to do this is by identifying domains of cognitive weakness, for example, to address weaknesses in attention or concentration, here potentially working memory. In the context of working memory, if you find yourself becoming overwhelmed with information, you and your therapist might work on methods for reducing cognitive burden, for increasing the amount of time provided for a task, and by streamlining or controlling how the information is presented. In the context of difficulties with attention and focus, perhaps you work on strategies such as planning tasks that have placed the greatest demand on you on times of day when you have the most resources. For example, some people find that they're at their best in the morning, and really trying to stack those critical activities during those periods where you're most likely to be successful. You might also break tasks into small achievable steps. You might get into a structured daily routine where the structure helps reinforce the behaviors that you want to see. Keeping lists, kind of digital records, those can all be helpful in a way to kind of reduce cognitive burden while also increasing the likelihood of a target response. You might also consider consultation with a board-certified neuropsychologist like myself to assess your cognition and provide recommendations for therapy. A cognitive assessment can be helpful for physicians to give them a full 360 view of your neurocognitive symptoms associated with Parkinson's disease. For example, Dr. Merola and I work closely together to assess Parkinson's patients as they prepare for procedures such as deep brain stimulation surgery or focused ultrasound ablation. Your physician may have identified providers within their organization who specialize in depression, anxiety treatment among individuals with Parkinson's disease or more broadly. You can reach out also to generalist providers in the community or close to home that can provide services. I think one of the most important things in choosing a therapist is that it's somebody that you feel like you can invest in, that you can talk to and you feel heard by, and that's somebody that you can stick with. So choosing a provider that's close to home has an advantage in that maybe you're not commuting so far. It reduces the amount of burdens or boundaries to attend therapy. Keep in mind there are lots of different types of therapists. I'm a psychologist. I have a PhD in clinical psychology and a specialization in neuropsychology. But other types of providers who might be suitable include counselors, social workers, marriage and family therapists. It really depends on kind of what your needs are and also what's available to you in your community. Formal neuropsychological evaluations and cognitive evaluations can be performed optimally by a board-certified neuropsychologist. There are a number of big institutions regionally who do them. Our colleagues at Cleveland Clinic in Michigan do great work. So there are a number of options. Chances are you can find somebody in your area who would be well suited for the job. So what are some common complaints that might signal the need for a neuropsychological test? What you might observe about yourself is that you, or maybe family members observe about an individual, is that they're struggling with their short-term memory, difficulty recalling conversations, things they did earlier in the day. Note that that's different than, it's very unusual for somebody to forget kind of more distant things. So you're probably going to retain the name of your favorite high school teacher while forgetting what you had for breakfast yesterday. That's a common complaint. So that short-term memory is really what we're concerned about. Also difficulty with finding your words, understanding others, visual difficulties, making mistakes functionally with medications and appointments, difficulty managing finances, maybe offloading responsibilities that you had previously managed, kind of finding them more difficult than they used to be, and having others help you with them. Those would be signals that perhaps seeing a neuropsychologist, getting a cognitive evaluation would be helpful to best understand how Parkinson's disease in the context of your overall health may be impacting your cognition and your mood. Neuropsychologists are clinical psychologists as well, so we may assess anxiety and depression as well, but it is less common for neuropsychologists to do weekly therapy. But we have great colleagues within the Department of Psychiatry here at Ohio State and kind of other institutions where we work together as a team to make sure that we have good continuity between the interactions you have with your physician, maybe with your neuropsychologist, and then with your therapist. Right. So I think I'm pretty good on time. Thank you so much for your listening and your patience. And it looks like next we have Dr. Patel.
Thank you, Dr. Boxley, for your presentation to give us an idea of what clinical therapy is and some of the neuropsychology that are needed for Parkinson's management. Next, I would like to introduce our next speaker, Dr. Patel. Dr. Patel is an experienced board-certified neurologist with fellowship training in movement disorders. His special interest includes Parkinson's disease, essential tremor, Huntington's disease, and dystonia. Dr. Patel is also trained in providing botulinum toxin injections for conditions such as chronic migraine, cervical dystonia, hemifacial spasm, blepharospasm, and head tremor and spasticity. Dr. Patel chose a career in movement disorders because of his innate love for caring for people, and is committed to taking the time to understand your condition and how he can support you and your family. His particular interest is in neuroprotection and effects of exercise on slowing down the progression of Parkinson's disease, in addition to non-motor symptoms of Parkinson's. In his spare time, Dr. Patel enjoys spending time with his family, exercising, cooking, and traveling. Dr. Patel, please share your screen to start your presentation.
Thank you so much. Welcome, everyone. I am so excited to be here and working with OSU and OhioHealth to help educate the Parkinson community at large about the importance of not only managing Parkinson's disease, but the impact that emotional and social wellness has on this disease, and multiple treatments besides just pills that are out there. She mentioned I am a movement disorder neurologist with OhioHealth here in Columbus, and my topic is going to be focusing on neuroprotection and involving the importance and treatment of not only just medication, but also emotional wellness, social wellness, and more importantly, and near and dear to my heart, is physical wellness. My disclosures, I do work as a medical consultant and a speaker bureau for AbbVie Pharmaceutical, Adamas Pharmaceuticals, and Neurocrine Pharmaceuticals, none of which impact today's presentation here. Parkinson's disease, as probably what you've heard so far this afternoon, this is not a disease that involves just a simple, here's a pill and you have a fix. Something I'd say to my patients very commonly is Parkinson's disease is not a cookie cutter disease. No two patients are the same. No two patients' treatments are the same. No two patients are the same in terms of what medication regimens they're on. And therefore, it is definitely important to keep a very open mind and integrate multiple disciplinaries, integrate multiple modalities of treatment when you're helping treat patients with Parkinson's. And there are lots and lots and lots of different things that are out there, and different things that continue to come out to this day. I've had patients this morning who have showed me other types of supplements and things that they've looked into or they've tried or they've read about and were curious to try. If you go through the literature, you could see many, many different options, whether it's naturopathic, Ayurvedic, Chinese medicine, traditional Chinese medications, chiropractic treatment, massage therapies, especially when you're trying to get some energy, acupuncture to help treat pain and rigidity. The importance the previous presentation talked about neuropsychological the neuropsychological components of Parkinson's and depression, anxiety, and being mindful and meditation, how important that is and what types of other biologically based treatments are, whether you're looking at herbal therapies or things like that. Many, 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 many things are out there. And I tell my patients, from what we could see evidence-based wise, studies have shown certain things that benefit. A lot of things have not truly been studied. And with Parkinson's, it's considered an advantage, disadvantage. It is a disease where, because it's not a cookie cutter disease and we don't have research-wise a perfect animal model that could be used for to look at research studies, and when that's being applied to patients and research clinical trials, things may or may not pan out just based on the way the disease is. But if it may be potentially helpful to patient without causing much harm, why not give it a try? One thing to keep in mind with this disease, and I tell my patients, nobody dies from Parkinson's. You die with Parkinson's, not from Parkinson's. And although we don't have a cure, it is something that affects someone's quality of life. And our job is to sort of work together as physicians, as patients, as family members, to all of us work together to help improve and maintain the best quality of life. Mind, body, soul, everything is interrelated. Everything works together. And when we have a healthy approach to a mindset, when you're treating multiple different things, it is extremely important to be able to put that in the forefront, because when all that's being treated, that's when you know your Parkinson's is also being treated very well. And exercise being probably one of the most important in terms of our approach with treatment. OhioHealth, we recently opened up our Neuroscience Wellness Center that is dedicated to patients with Parkinson's disease, and to help give them that exercise treatment, the therapy regimen that we know is so crucial, that we know truly slows down the disease in Parkinson patients. And all throughout the state and country, more and more exercise programs are being developed and are continuing to be developed, because we're starting to see not only where there's Parkinson's, healthy, normal aging, things that's out there, whether it's Parkinson's, Alzheimer's, heart disease, you name it, brain health, heart health, physical health, and the importance that this does these patients, really, 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 really crucial. This table kind of goes through kind of very much so more simpler basics in terms of stretching and types of things that are out there, and what we should be looking at, what you should be doing, how much aerobic exercise is good. A lot of times patients ask, well, how much should I do? Do it. And there are patients who are on an extreme where their entire day is focused around exercise, and there are patients that it takes them a little bit. They need that push. They need caregivers on and say, no, you have to get up and move. We need to do this. Dopamine is your get up and go chemical. It's what makes us get up and move. And when Parkinson patients are lacking it, sometimes they need that push. But they know, and they admit, once they start doing it, how good they feel to do it, that they'll want to keep doing it to maintain that healthy physical body, mental body, emotional body, to maintain all that for a healthy brain health. 2020 was a very unique situation for everyone. And one thing that we really took out of the pandemic and how that affected Parkinson's patients is we really got to see the importance of social wellness. March 17th, 2020, the world shut down for the pandemic. And what did that show? We saw that, albeit Parkinson's is a very slowly progressive disease, when social isolation had to occur, when people were away from their therapies, they were away from their normal routine. Human beings are social beings. We're meant to be social. And all of that was taken away. This slowly progressive disease exponentially got worse. People who didn't have that support are increased susceptibility to have stress, poor immune response. And therefore, when you don't have that and you get a viral illness, whether it's coronavirus or the flu or whatnot, you have a much more difficult time to respond to that. Your body's immune system is not working as well in these situations. You know, we could see studies have shown loneliness causing stress-related, all sorts of different difficulties with inflammatory responses. Elderly, middle-aged patient cognitive processing significantly affected in these patients. In fact, in some studies showing social isolation being just as detrimental as smoking and obesity can be. So, and this past year, you know, we were kind of put in the forefront. These studies that were done by University of Florida showing this kind of what does this mean, and what impact did this have on our Parkinson patients? We know Parkinson patients is a quote unquote old age illness, which even that we're seeing that, you know, doesn't necessarily have to be the case anymore. Younger patients who are getting diagnosed with Parkinson's, who still had to work, who still have a family to support, and still have to incorporate all these things, can become extremely difficult for them. And as they age, what that does to this disease, and what that does when you lose any sort of societal norm, when you lose that social well-being, the impact that it takes on patients. This graph is probably a little bit blurry. I apologize for that. But again, in the same study that was just recently published by Dr. Subramanian, showing that the impact of quality of life here, and how he says is when patients who admitted they have quote unquote a lot of friends, the higher the number of that, the higher the impact of their quality of life that they had. And same thing in terms of tremor severity, significantly less. When they're lonely, then as a result of that, they have much more. Their impact of their quality of life is much poorer. The 4% versus 73% lonely, poor quality of life, higher tremor percentage, showing the impact that social health has on quality of life for Parkinson patients. And again, you could see it in multiple different ways here, when patients would say, you know, how well do they feel? What do they feel with their Parkinson's symptoms? When you compare it to how social they are, there's a clear-cut correlation. Patients who were felt to be lonely did significantly worse. And so the importance of this, to keep in mind that, you know, this was sort of our society experiment this past year, and we saw that very clearly with our Parkinson population, that the impact of this, and to keep that social wellness going. And when you do get lonely, you could see the impact that could have on patients' motor symptoms, not only their motor symptoms, but autonomic symptoms, their psychological symptoms, cognitive symptoms, increased hallucinations, increased memory power, increased fatigue, insomnia, anxiety, can become much more problematic for them. When they're lonely, you could see this light graph here that represents patients who were felt to be lonely, and how much percentage that had, compared to the dark, which was they were not lonely and therefore had much less of these symptoms. So, and then physical wellness, get up and move. Such an important concept to give our Parkinson patients. And not only you want to do that for your physical health, but it's shown in Parkinson literature. It showed this significant slowing down of this very slowly progressive disease that we don't have a cure for, but down to the chemical measurements, where you could go in and see protective factors that we have for cells to be protective or to decrease cell death. These enzymes that get released when patients exercise to protect the brain. It's neuroprotective. You know, when you do this physical exercise, you increase cardiac output, more blood going to the brain. More blood goes to the brain, more oxygen goes to the brain, more nutrients go to the brain. When you have that, and you have this potential cell death that's happening because of the disease, when a cell is dying, it's releasing these other factors that are also causing other cells to die. But now if the brain is getting this healthy environment, it's now able to use that healthy environment to kind of get rid of all those bad things, to be able to protect cells from continuing to progress, to prevent them from having that slowing down that progression even more. And the importance of that continues to be shown in the cellular level as well as the more overall physical level. Studies, many studies back from for years now have showed that patients who do have a routine exercise or who are active, whether it's walking, stretching, multiple exercises, a Japanese study with over 400 Parkinson patients, they had a much less mortality rate than the patients who are not active. Physical activity helps Parkinson patients maintain their psychomotor learning, to be able to do, when you exercise, and after you exercise, you now have, the brain is able to then, right, that post-exercise point is when it's really able to kind of take on that learning, take on what they need to know. The exercise, you learn to take big steps, you learn to speak louder, you learn to move better, you bring in to decrease that potential for cognitive decline, to help continue to learn new things and move better and do more things. Continues to be evident, whether it's non-motor symptoms, motor symptoms, all of it continues to be shown. I mentioned this already in terms of animal models showing that these the factors that help protect the brain and increase brain health, but by decreasing destruction in the brain when patients exercise. Lots of models have shown this to be the case. Mice models have seen even 18 months after they've done exercise, they continue to see improvement in movement and balance. That remains to be true. In the substantia nigra, where we know dopamine cells are, where the dopamine cells are being lost, the patients, whenever they have models that do exercise, you can measure and actually clearly see that they have restoring function, that the patient, these models are doing much better. And when you don't have that, when you don't do that exercise, you then also see the lack of it. You see in not exercising rats, there were cell volumes went down, fewer cells there, so which increases risk for balance, increased risk for falls, because the cells are continuing to decline. So doing this, exercises cannot be stressed enough. Cleveland Clinic has continues to show when they're doing forced exercise models where patients are being put on bikes that is also pedaling for you, and doing that, you start seeing continued improvement in concentration of these factors in the brain that can help protect the brain cells from dying off. And the idea with exercise is that, for Parkinson patients, it's slowness, stiffness. It's not necessarily strength. So the idea is to become faster, become more agile, become less stiff. And if we're able to do that by doing these aerobic components, these pedaling, things like that, to get patients to go as fast as you can, so that you now are able to become faster, less slow, less stiff, move better, therefore less chance of falling, and more ability to have a better quality of life. A lot of patients ask, well, what should I do? What can I do? And again, places when you go to, whether it's with neuro rehab, physical therapy appointments, neuroscience wellness center, they will have all that there for you. But also when you at places where that may not be available, simple things. Stationary bike. A lot of people have stationary bike. Most people, that stationary bike is probably a clothing rack rather than actually being used as a stationary bike. And so I tell my patients, get rid of the clothes, keep the resistance at 0. Remember, it's not about strength, it's about becoming faster and looser. Pedal as fast as you can. If you've ever been to a spin class, you could know how difficult that could be to do pedal as fast as you can for about 30 minutes. Ideally, get up to 80, 90 RPMs. Do that however long you can. And then when you get tired, stop. Work your way up to 20, 30 minutes a day. Walking, maintain that walking, especially right now where the weather's nice. In the winter, maybe a little bit more difficult, but try to get out there as much as you can. And things anywhere from ballroom dancing, tango, yoga, tai chi, you name it, has all been continually proven. As long as you're doing something, you're getting up and moving, that's the important thing, and to do it in a health and safety way. And I can't stress this enough in terms of whether you want to talk about social wellness, you want to talk about emotional wellness, physical wellness, to this day to be true, the only thing that's improving to slow down Parkinson's disease, exercise. Here are some of my references for the trials that I had mentioned regarding social wellness as well as the exercise therapies. And I will now hand it over to my colleague, Melinda McGuire.
Thank you, Dr. Patel, for discussing the neuroprotective benefits of emotional and social wellness and exercise in Parkinson's symptom management. And now I want to invite our last speaker, Melinda. Please do continue to submit any questions using the Q&A button as we are moving right into the Q&A session after our next presentation. Melinda McGuire works at the Dempsey Family Education and Resource Center in Riverside Hospital, where she is the social worker and the program coordinator. She facilitates support groups and classes to assist patients and family in finding resources. She has her bachelor's in psychology from Wright State University and her master's in social work with a specialization in aging from Ohio State, where she also completed an advanced certificate program in serving veterans and their family. Melinda, please share your screen to start your presentation.
Hi, thank you so much. I am so excited to be here and to be a part of this. So now that we've heard all of the medical and clinical information today, now we get to talk about the fun stuff. I always say that doctors and nurses and psychologists are like your parents. They're there to keep you safe and healthy and pain-free, but social workers are kind of like your grandparents. We're here to find out what you like to do and to help you do that safely. So we are going to talk about the benefits of creative therapies today. And I don't have anything to disclose. So when I was first asked to present about creative therapies, I thought, oh yeah, I can talk about music therapy and art therapy. But then as I started thinking about it more, I realized that there's so much more to creative therapies than music therapy and art therapy. And so we are going to be learning different types of creative therapies today. We'll talk about music and art, but we'll talk about some other things too, what the benefits to those therapies are. And then we're going to talk about one of my favorite things, and that's support groups. I facilitate a lot of support groups. So these are the therapies that I will touch on today. There are other types of therapies, creative therapies or different therapies. And I know that Dr. Patel mentioned some of them like massage and Tai Chi and yoga. I'm not going to talk about those, but we're going to touch on art and music, also dance and recreation, a little bit on journaling. And then if anyone knows me, I know you guys don't, but anyone who knows me knows I love to laugh and have a good time and smile. And so I'm going to talk a little bit about humor as well. So when I think about art therapy, I think that I have to draw something, and I'm a terrible drawer. And if you consider yourself an artist, you probably know that there's more to art therapy than just drawing. But if you're someone like me who feels like a 4-year-old knows more about art than you do, then your definition might be limited. So let's look at this picture a little bit. So of course there is drawing and painting, but painting can be just even free painting. It can also be working with different mediums like paper or fabric or yarn, things like that, but then also using those clay and pottery. And I didn't put it on the slide, but I even thought later about even photography. So we offer an art therapy class here, and one of the art therapy interventions that our participants did was called a safe place. And so they were encouraged to visualize a safe, peaceful place. It could be real or something they imagined. And then they were supposed to create an image of that space. They were supposed to consider what was around them in their space, maybe what was above them or below them or beside them. Think of places that made them feel safe. And what was in those spaces. They were encouraged to use their 5 senses, their sense of what they might hear or taste or touch, smell or see, and think of if there was any boundaries that they had around their safe space. And then they were supposed to create an image around that. And so again, to me, I'm like, oh, I'm going to draw trees in a hammock because my safe space is a hammock in my yard. But one of the participants took fabric. So she went into her fabric closet and she got fabric that maybe had seashells on it to represent her time at the beach, fabric that she had covered her grandmother's love seat in, fabric that had been that she had made clothes for her children in, and she took that fabric and she made a collage out of it. So she was thinking about all of the times she felt safe, when she was at the beach, when she was with her kids, when she was at her grandparents' house. And she made this piece of art, and then she hung it on the wall to remind her. So if you think about that art intervention and think about maybe these benefits of art, so you know, increasing your hand dexterity, again, using scissors or a paintbrush or modeling clay to help strengthen your hands. And certainly it was helped with her self-expression. It was things that she loved to do, represented people that she loved. It increased her positive mood because as she was doing this, she was thinking about those things. And as her mood increased, that decreased her depression. And then in terms of improving her quality of life, again, that's something that she hangs on the wall and that she sees each day as she walks down the hall that can remind her of those things that help her to feel safe. So then let's move on to music therapy. And I have a few funny pictures on this slide. So when we think of music therapy, we think of active music therapy, maybe being in a choir or being in a drumming circle, or even writing music. But there's also passive music therapy in terms of listening to music that you like to hear. But then what's up with this picture in the middle with the gait belt? Well, this is really cool. I don't know if any of you have ever heard of this or seen videos of it. I've seen videos of it, but there's something called rhythmic auditory stimulation. And that is if you're having trouble with your gait, if you're having trouble walking slowly or having shuffling steps or having difficulty picking up your feet, if you actually walk to the beat of music, the rhythmic auditory stimulation, it actually helps with your walking and with your gait. And so there are lots of benefits to music therapy. Again, that increasing your positive mood. How many of you can be in a bad mood or a poor mood and put on music and listen to it, maybe from your childhood or maybe from your wedding or maybe something that reminds you of your dad or your grandparents, and that instantly improves your mood. So it increases your mood. Again, that rhythmic auditory stimulation can help with your gait and your extremity function. It also improves your memory. So here at the Dempsey Center, we have a neuro choir, and I know there are other choirs around too that are specific for Parkinson's patients. And so learning that music and remembering the lyrics and remembering how the song goes can help with your memory. It also helps with self-expression. So our neuro choir here at the Dempsey Center, they write songs quite frequently. And just recently, they wrote a song called "What Do You Do With Your Messed Up Neurons?" So that was an acknowledgement that things aren't always the way they want it to be in their life. But what do you do with that? And how do you get past that? It was to the tune of A Drunken Sailor, and they all kind of got together. They all wrote their own verse to it, and then they're working right now actually on putting together a performance video to put that out on YouTube. And then finally, studies have also shown that music therapy can help with decline in voice quality. So as you're singing and as you're taking those deep breaths, and a lot of music therapy has to do with your breathing in and taking deep breaths, it can help with your decline in voice quality. So I wish I could see you all. I always say I like to have a conversation rather than give a presentation, but even though I can't see you, if you like to dance, give me a thumbs up or nod your head. So dancing is something that can help with Parkinson's as well. And specifically something called improvisational dancing, which is the spontaneous creation of movement. So it means that you're inventing movement as you go. When you hear a song and you like it, you just kind of begin to move to it. No one wants to see me do that. But even though I'm not very good at it, again, if you think as you're moving and having a good time and interacting with people, that helps your mood. So dancing can assist with balance and cognition and gait. So it has those physical benefits. But again, I want you to think about when you're in a group, when you're at a wedding, when you're at a party, and you're just kind of even moving to the music, how that helps you increase your mood and decrease your depression. This next slide was put together by a friend of mine who's a recreational therapist at OhioHealth Rehab, who obviously can do PowerPoint slides much better than I can, but she has spoken at a couple of my support groups. And this research was actually in terms of any neuro condition, not just Parkinson's. But you can see as you look over this slide, it's all about quality of life. So just because you have Parkinson's or another neuro condition, it doesn't mean that you have to quit living your life. It doesn't mean that you have to quit doing the things that you like to do. And recreation is so important to help decrease that depression, improve that mood, to help with your quality of life. So I want you to think about, what do you like to do? What have you liked to do in the past? Can you still do it? If you can, keep doing it as long as you can. If you can't still do it the way you used to, maybe you can adapt it in some ways. And there are a lot of programs out there that can help you adapt what you like to do. So we have a 4-Hope golf program here at OhioHealth that helps people golf, even if they need some adaptations. Maybe you can't do what you used to do before, but there's something else that you can do instead. And so one of my Parkinson's support group patients loves to play pickleball, and that is something that he is still able to do. So it could be even that you need to find a new activity, but the most important thing is to keep doing it, keep engaging, keep doing activities. It's so important for our quality of life and our well-being to continue to live your life as best you can. I also wanted to touch just a little bit on journaling. So we have a journal club here at the Dempsey Center, and before I actually now facilitate it, before I facilitated it, I thought, well, I'm not a journaler, because I always thought kind of journaling was kind of like writing in a diary where you had to write pages and pages or pour your heart and soul out, and it might be time consuming, and when do I have time to do that? But again, as I work with this journal club, I realized that journaling can be as little as writing a sentence a day. It can be writing down what you're struggling with or pages, but it doesn't have to be. It could be a line a day. It could be a list of things. Something really popular right now are gratitude journals. So just every day, either write a list of things that you're grateful during the day, or even just one thing a day. What am I grateful for today? It's a place that you can be honest. In our journal club, we share what we journal, not everything if you don't want to. So it is something that you can share with other people, that maybe they can get a benefit out of learning what you've written, or it can be something very private. It's a place that you can be totally honest about what you're feeling. Now, I promised you that we were going to talk about humor. So as a social worker, I will tell you, it's okay to feel all the feels. Having Parkinson's can make you angry and frustrated and sad and depressed. I get that. It's okay to feel that way sometimes, but you don't want to stay in that place. So one of the ways to move through those feelings is to find humor, maybe in your situation or maybe outside of your situation. Let me give you a couple of examples. So I have a patient who, she was going out to her mailbox to get her mail, and she fell and she couldn't get back up. And so and luckily she wasn't hurt, but as she was laying there on the ground, she looked up and noticed the sky was just beautiful that day. And so she pulled out her phone to call her husband. And before she called her husband, she snapped a couple of pictures of the sky, and she texted him the pictures and said, "Oh, hey, by the way, I'm laying on the ground by the mailbox. Can you send somebody to help me?" So, when she tells that story, when he tells that story, when I tell that story, it brings a smile to my face, because it just shows that even in difficult circumstances, you can find some good if you're looking for it. I also facilitate a Parkinson's support group, and there are 2 gentlemen in that support group, and they are both retired pastors. And so they have put together this little comedy duo called Parsons with Parkinson's. They read a book, and in that book, it talked about people with Parkinson's being called Parkies. And so now they do a take on the Jeff Foxworthy, "You know you're a redneck if," but theirs is, "You know you're a Parkie if." And they have gone to different support groups in the area, different Parkinson's talks, but more importantly, they've also spread that message even further than the Parkinson's community. So I've had them come speak to my stroke group, because again, even though stroke and Parkinson's are different, sometimes you have those same struggles, and it's a way for them to help motivate and encourage and get people to laugh and see humor in their situations, not just Parkinson's patients, but even anyone who struggles with anything. Now, if you can't find humor in your situation, that's okay. Sometimes that is really difficult. So maybe you could find humor outside of your situation. Maybe that's listening to a funny podcast or watching a TV show, or once we're done being over COVID and being kind of isolated from COVID, maybe you could go to a live humorous show again, or even reading a funny book. There are so many ways that you can get humor into your life. We have a gentleman here at Riverside where I work, and he works in parking services, and every day he comes in and tells us a joke. And most of the time, they're so lame that you have to laugh at them, but it's just a way to bring humor into your day. I've also heard of a laughter yoga. I've never been in it before, but I do know there is something called laughter yoga, and that is a good way also to kind of to get to laughing and to get humor into your day. So I know Dr. Boxley touched on support groups, and I just want to say some of the same things she said in terms of it's so powerful when you hear somebody in a group say the exact same thing, this exact same thought that's in your mind. So I think sometimes support groups can get bad rap because they think it's just a bunch of people sitting around crying or complaining or telling deep, dark secrets. And some of that happens sometimes, but it's so much more than that. It's a sense of community. It's people coming together and understanding what other people in the room are going through. And it might be that you say, hey, I'm really struggling with this week. Or it could be you say, hey, I was able to walk a little bit further this week. Or, hey, you know, my medication's working a little bit better this week. So there is some of that. I'm struggling with this. What can I do to help with that? But there's also, you know, sharing the positive too. It's a place where you can talk to people who understand what you're going through, and you can say things that maybe you don't feel safe saying to anybody else, but you feel safe saying it to someone who has Parkinson's disease because you know that they're going to understand it. And hopefully when you find that support group, it's not going to be just a group of people that you meet with once a month for an hour. So our Parkinson's support group that we have, when COVID hit, of course, everyone was isolated, and there was one gentleman in the group, and he started sending out a weekly email with a question, and then everyone in the group would answer the question, and they stayed connected through email all through the pandemic. They still do. They even wrote an article up and put it in the Columbus Dispatch about this group and how important social connection is during times of isolation. And they are not only a support group, but they're friends. So they've just recently started meeting outside of the support group at a breakfast place once a month on a Friday morning. And they don't talk about Parkinson's or their medications or their difficulties. They talk about life. This is what my grandkids are doing. This is where I went on vacation. You know, this is a TV show that I watched that I really like. They are doing life together. So as you look for a support group, find that group of people that you can do life with. That's important. So this last slide, and I know that the participants are all over, not just Ohio, but our neighboring states as well. So this is some program availability, mostly in Central Ohio, but I wanted to point out that thanks to COVID, most of these things are also offered virtually as well. So again, I work at the Dempsey Center. We're physically located inside of Riverside Hospital. But all of our programs currently are being offered both in person and virtually, so you don't need to live in Central Ohio to participate in any of our programs. I'm sure that you've been on the Parkinson Foundation website, and if you have, you know there's a list of support groups there. There's also a list of different exercise classes and things like that. There, besides our neurochoir that we have here at the Dempsey Center, there's a neurochoir called Tremble Cloths. Again, it's here in Central Ohio, but they are doing things virtually, and that there is the Pam's email address if you're interested in that group. And then finally, I wanted to give out a shout out to our cohorts at OSU because they're doing some great things over there too. So I know that they do some dance and some voice and some fitness classes at Ohio State, and I also know that they are doing some things virtually. But if you're not in Central Ohio and you don't really want to do things virtually, a lot of the Parks and Recs department have programs available, and there's different adaptive sports connections that you can make as well. So thank you so much for listening to me, and I hope that I've given you some ideas on how to improve your quality of life with creative therapies.
Thank you, Melinda, for sharing all the resources of creative therapies and support groups. As you were saying, because we're in the COVID setting and you're not in the Central Ohio areas and is available to some of the things that Melinda has talked about, our helpline is really great. They have a list of resources that you could be able to participate locally and to look up any of the local resources that are available closer to you. You could also see which chapter of the Parkinson's Foundation you are closest to and you're local to, and they'll be able to also direct you to some of the wellness programs there as well. So we have received quite a few questions from our registration and live audience today. So please feel free to continue to use the Q&A button to submit your questions. And while the questions are coming in, let's jump right into the questions. Okay. So I'm going to start with Dr. Merola. What are things that a caregiver or care partner to do to best to help loved ones that are experiencing hallucinations? So this person has a sister who has hallucinations and delusions. And how can we communicate with them, especially in a social setting?
So in my experience, the patient who is experiencing hallucination sometimes feels ashamed because he or she realizes that the hallucinations are not real, and therefore he doesn't want to be judged. And sometimes this creates part of the problem. So what happens is the patients do not report the symptoms, they tend to hide it. And of course, this is not constructive. So my strong recommendation is don't be judgmental. It happens all the time that I ask my patient, do you have any hallucinations? And maybe there is a family member in the room that looks at me like I'm saying something crazy. And the patient says, yes. And at that point, the family member realized that they were not aware of that. And why they were not aware of that? Because the feeling maybe you feel ashamed by that, judged by that, considered crazy, or like not being able to drive or to do other stuff, stay at home by themselves. So be comprehensive. This is a problem that can and should be fixed. But in order to be treated, first it needs to be identified and reported.
Thank you for the answer. On the opposite side, what if a caregiver is noticing that there's hallucination or impulse control issue, but then the patient themselves is not recognizing it, or maybe even in denial of it?
It can happen sometimes, especially when there are UTIs or infections, there may be a little bit of delusions. And so some common delusions are like, a neighbor, maybe he's doing something, or there might be, this is not my house, or somebody replaced my house with a different environment. So these usually are episodes that can come because of some trigger, such as an infection or dehydration. The suggestion is never argue. Try to understand that there is something a little bit, off. Try to be very gentle, very kind, but also redirect in the proper way. Like saying, okay, this is your house, but try not to get emotionally involved into that, but rather to be understanding that the person in that moment is having a difficult moment.
Right. Thank you.
You're welcome.
Another question similar to that is increased sexual behaviors or hypersexuality. I know that sometimes comes with impulse control, where we have to talk about social appropriateness, right? Because we're talking about emotional and social wellness. What are some strategies and what are some things that a patient or a caregiver could do to address that issue? Dr. Merola, I apologize.
Oh, is it all the questions to me?
Well, just go down the list.
Can I redirect the question to Clarisse or to Dr. Boxley?
Of course.
Clarisse, you're on mute.
Clarisse, you have to be on mute. No.
Answer briefly a little bit, but from my perspective, when we have folks who are struggling with impulse control, we want to think a little bit about putting them in environments where they can be successful. So trying to reduce the kind of opportunities where they might be tempted to act out or have difficulty controlling themselves, so that we're not placing in a position where they're continuing to have a difficulty. I would also say that it's not really a matter for most folks, it's not something you can negotiate very well. Like, it's not something we're talking more and more about. It would necessarily always be helpful. So really thinking about how can we as a team or as caregivers provide an environment that's most supportive of what they can manage, and how can we make sure that we're putting them in a position where they can be successful.
Thank you. The next question is for Clarisse. How do you find an advanced provider specifically trained in Parkinson's?
Well, usually they work at movement. They usually work at the larger centers where there's a movement disorders division. That's how we are specially trained. We are usually trained to some extent on the job, but usually for a long time, 6 months to a year, on top of the training that we have already. So we're not usually out just about by ourselves, but at any of the larger facilities, you will almost always find a nurse practitioner or a physician's assistant. They have them, and just locally, OhioHealth, Ohio State, and Cleveland Clinic has them, just off of the top of my head. But most movement disorder centers do have APPs. Thank you.
Got it. And Clarisse, kind of going off of that, I know we talked about having a multidisciplinary team, but what if you're not at one of these bigger centers? Is it appropriate then to seek out, for example, a PT at another clinic, or OT somewhere else? What would that kind of look like to make your team?
Oh, sure. Sometimes, well, there's a couple different ways to answer that. One is that with the new virtual clinic options, that we have for several things, and that COVID has really brought to light, maybe you see your local neurologist and your local team more frequently, but maybe you come to a bigger center once a year, or maybe you come to a bigger center twice a year and you do video or telehealth visits in between. But when it comes to some of those extra folks, especially like PT, OT, and ST, there's a website that we often check, the LSVT big website, or some of the other different trainings, specifically for Parkinson's disease, that we can always look and see if there's a local provider. But even if there's not, typically we can find someone who has some training near you. But if not, then we're also just happy to get you into physical therapy or speech therapy, and those folks can definitely be very helpful. I know here at Ohio State and other facilities close by as well, that we're really trying to focus more on the multidisciplinary clinic model. So hopefully at some point, our patients that do come farther away, we will be able to get them in to see multiple providers that they need to see all on one day, or a couple of days close together, to also reduce some of that burden. So either telehealth options, or seeing us once a year, and local folks more frequently, if that's helpful at all.
Thank you.
And I also, let me just add this, because this is a common point that I've been asked. So patients sometimes they are worried about not being loyal to one center or to another center. There's no such a thing. So don't be worried about that. So sometimes I have patients that ask me and say, "Doctor, but how do you feel if I do delay the disease at the OhioHealth?" I say, "Of course, go. It's a good program." So this doesn't mean that, there are some things that are not productive. For instance, shopping around with two different doctors at the same time is not productive, because you are asking the same service to two different providers. So it can make sense asking second opinions, but then later you need to find a provider you feel comfortable with and stick with that. But sometimes, there might be certain programs that might be a little bit more convenient for you, they might be better for you, or, for one reason you prefer that program, and you can have mixed programs. Nobody takes this personally. And I'm also so proud that here both Ohio State and OhioHealth are partnering together, and that's the message we want to give. This is about collaboration against the disease. There's no such a thing like rivalry between institutions.
Thank you for pointing that. Dr. Boxley, the next question is for you. My partner is hesitant in joining group therapy or therapy sessions in general. What could I do to help them convince them that it would be helpful?
Yeah, I think some people might feel that they might have concerns about therapy broadly or the group context. So getting some more information about, is it kind of being symptomatic in front of others, or maybe a lack of familiarity with therapy? Kind of hearing about what their concerns are based on kind of common concerns I get would be just a lack of experience with, what it's like to be in a group, or sharing that vulnerability. For some folks, I think going into individual and then maybe getting their feet warm and then kind of transitioning to group could be one option. If somebody has some social anxiety, there's lots of great goals that you can have in the context of individual that are well received in the context of group as well. But I would encourage them that group has that really unique value of interacting with people who know exactly what you're going through, and that knowledge and that wisdom, their experience, that's all something that you can benefit from, as Melinda had talked about. So I think group also can be a little bit, I enjoy group because you can also listen to other people. You don't have to be quite as actively engaged initially if that's helpful for you. So really, I think there's a good fit for just about everybody out there. And I would encourage that person to explore a little bit. But if it's the social context, if it's the group, individual might be a nice bridge. You can also do a telehealth that can also onboard people where talking to somebody via video may be a little bit less threatening than walking into a big building and talking to somebody. So the most important thing is that you find somebody you can connect with and you stick with it. Whatever flavor works for you is great.
And I want to add to that, and I know support groups are a little different than group therapy, but again, Dr. Boxley mentioned kind of telehealth individually. That's the nice thing right now about support groups that are virtual, because you can literally join, you can leave your camera off, you can stay muted, and you can listen for the first couple of times. You don't feel like you have to participate, and you can get a feel for the group. And is this a group that is going to be helpful to me, or is it not going to be helpful? And if that group isn't helpful, you can move on and maybe start virtually and then maybe eventually end up in person.
That makes sense. So a follow-up question for both Dr. Boxley and Melinda. What are some of the therapy that are, or support group that are available for caregivers?
Go ahead, Melinda, you go first.
I know here at the Dempsey Center, we have a couple of different caregiver support groups, and some of the Parkinson support groups allow caregivers to come. Some of them are specifically for patients, and some of them are for patients and caregivers both. But I know we have a general caregiver support group here, and it is virtual. So.
Yeah, I believe we have individual therapy for caregivers, and we have some identified providers who specialize in that. I don't believe we have any current groups for caregivers, but I know that the Caregiver Alliance, a lot of the Parkinson's organizations, they have great caregiver virtual groups as well. They may also have, often will list kind of regional access to caregiver resources. So I would definitely recommend, if you're looking for a group experience, to access those online resources to see what options you have both in person and via video.
Thank you so much. Dr. Patel, the next question is for you. Regarding exercise, is there data as to what time is best to exercise? Because especially with endurance and sort of the medication on and off time, what is really best and when is best to exercise?
Yes, can you hear me?
Yes.
Okay, sorry, I have to pick up my son from daycare, so I switched my video off. So you hear me. So yes, to answer the short answer is anytime, as long as you're able to do it. Some people, when they're off, they're really struggling to really get up and move and be able to become that looser, stiffer. So when they feel on, they feel they have more energy and they're able to do more during that time. So that's a good time for them. First thing in the morning, where they're up, they had breakfast, and they're able to then have that sort of mindset where, okay, you can now bring in that psychomotor learning for the rest of the day, you have those endorphins built in, and that really seems to help. But then I have, they're young onset patients who are working 8-9 hours a day, and then they really aren't going to be able to do their activities till closer to the evening and towards the end of the day. So in terms of the evidence-based stuff, it really is just doing it. And when you feel best that you have that energy and time commitment to be able to do it. Everyone's situation is different, whether you're retired or not. So when you feel like you can do it is ideal to get the most bang for your buck.
Thank you. Just a follow-up question is, some of the cognitive issues for people living with Parkinson's is the lack of motivation or apathy because they're potentially dealing with depression and anxiety and so on. So how do you balance that lack of motivation to the need of exercise? What are some strategy a person could use to get the motivation to exercise, and what could caregivers do to help out with that?
Yeah, so and there is a slight difference between apathy and depression. Apathy, where you're at, that's that dopaminergic drive that you just don't have that you don't have that will. You're just kind of you sit there, you let the world go by, but you're not necessarily sad. And depression, you're dealing with the sadness component that's involved with it. So if there is true underlying depression going on, and we've talked about this earlier, 50, 60 Parkinson patients have comorbid depression, anxiety. And when that's going on, if that's not being addressed and treated, no matter how much levodopa you give someone, they're never going to feel better. So it's extremely important that if it's sadness that's happening, if there is this depression that's happening, then it's extremely important that caregivers and patients talk with their medical provider to let them know that, yes, this is happening, to be able to address that in multiple ways, whether it's psychology, medications, you name it, to be able to get that better so that you are then able to then have that energy and drive to be able to exercise and do more. And if it's not depression, anxiety, if it is really apathy, then that is where it becomes.
Okay, looks like we might have lost Dr. Patel. Dr. Boxley, did you want to add anything onto that conversation?
Yeah, I was just going to add that, when somebody might be struggling to engage in a target behavior, we might recommend pairing those things. So maybe it's not just walking, but walking with a partner who's expecting us, or doing something pleasurable like have patients who are bird watchers, who have family members who play sports. And so getting out and walking can be part of attending events, doing things that kind of pay dividends on multiple levels. And so I would encourage you, if you're having trouble finding the motivation or energy to do something for the sake of doing it, let's see if we can augment that activity and kind of create more opportunities for points of access for that activity. Maybe if it's difficult to walk, maybe we go to an art museum where there's lots of benches to take breaks, but it can kind of motivate me to keep moving my body. It can look like whatever you want it to look like, as long as it suits you and it feels good to you. So I think creativity around that, please be non-judgmental around that. Whatever it takes to move your body, we're going to be really excited about.
I'm sorry, did I get cut off? I apologize.
Go ahead. Did you want to finish your
Thank you so much, Laura. No, what she was saying, I completely agree with. It really is that, whatever it is that you know the patient is gonna enjoy doing, it's gonna take push from caregivers and loved ones to say, let's just go do this, let's get up and move. And as soon as they do a little bit, they are gonna start feeling better, and then they will then want to keep doing it. But it is going to be like, no, we're going to get up and go. We're going to get up, we'll do this, something you think they will enjoy, even if it is just for a few minutes. But you can build on that. You start from somewhere and you just keep building on.
Thank you. And this one's for Dr. Boxley and potentially Melinda as well, because we were talking about in a group setting, a social setting, where PD patients could work on things like memory tasks or play games together, like card games and things like that, where they could work on their cognitive and memory wellness.
Yeah, I would say the things that are most cognitively beneficial are the things that are complex. I like social interaction for cognitive complexity. You can play games as long as you enjoy them, but I think what we're really looking for is the challenge. The challenge is where we see the benefit and the promotion of kind of cognitive functioning moving forward. So if you're really good at crossword puzzles, you're gonna have to pick something else because it's the challenge that we're driving at. So I would recommend if you feel like joining a book club, reading text, kind of consuming it, sharing it, that's very cognitively complex. If you like to sing or play an instrument, kind of learning new music, those are all great challenges. So I don't think there's a secret game or a certain type of game. I really think it's just neurons that fire together, wire together. Let's try and think broadly about that and try and get you to be engaging and staying social, because I think it's very common for your world to get concentrically smaller with Parkinson's disease, going out less, being concerned about interacting. We want to push against that. We want you to engage with your environment, with other people, doing things that are enriching physically and cognitively.
Thank you. So we want to take a moment and turn back to talking a little bit about medication. What is medication versus symptoms of medication and how that's affecting cognitive versus actual cognitive neurophysiology issues that need to be addressed. So Dr. Merola and Dr. Patel too, we wanted to talk a little bit about how to handle and how to talk to your physician about what may be medical issues in terms of medicine and side effects versus is my person with Parkinson's or even the caregiver's perspective, are they actually more symptomatic in terms of neuropsychology?
It is not simple. So distinguishing what is related to Parkinson itself from what can be a side effect of the medication is not always that simple. And in my opinion, it's always difficult to do this over the telephone or over a my chart message. So every time there is something that I perceive as a problem, I always ask my patients to come over, just because seeing the patient in person, talking with the person, discussing the nuances, it really, it tells you the truth. While sometimes, recommending take a little bit more, a little bit less, in my experience is a recipe for a disaster. So it happens all the time that somebody says, oh, I have hallucinations, so maybe I'm taking too much levodopa, can I cut down? And maybe in the moment you say, okay, try. And 2 days later, things is going very bad. And so I say, come over. And you realize that the hallucinations were related to a UTI. And cutting down the dosage only made it worse. So as my colleague Patel said before, this is not a cookie cutter disease. Every case is unique. Physicians working in this field are frequently physicians. I've been doing this for years and years, and there's a reason for that, because experience is really critical here.
I agree. And one thing that, like what Dr. Merola said, it's hard when if it's just a message you're getting or a question, what is this? You kind of have to see the patient, but something as for patients and what patients and caregivers can do. And one thing I like doing when I'm diagnosing a patient or starting medication is give a patient a journal and kind of be able to say, okay, at this time, this is my schedule, this is when I'm taking my medications. And then when they're experiencing something, whatever it may be, and the question is it a side effect of medication, or is this part of the disease? Kind of see, when is it occurring when I take my medication? Is this something that's occurring because you're potentially coming off your medication? Is this something because it is peaking medication wise? Is this completely different? We know Parkinson's is a slowly progressive disease. And as a result, when there is a sudden change and there's all of a sudden something's going on, then yeah, we are concerned more about UTI, something like that. So getting more of the information from patients and caregivers as to what's going on to help determine, is this a medication side effect or a disease progression situation. But timeline with when this occurs regarding medication dosing is always helpful to help kind of figure that out with your provider.
So again, just being able to kind of recognize some of the symptoms and being able to communicate that with your provider so that there's a plan going forward. Dr. Merola, we had a question about DBS. And maybe Clarisse could also add on to that. Could cognitive symptoms be different for those who have DBS? and could confidence be improved if they have DBS? So how does someone become eligible for DBS, and what are the symptoms that may be different in cognition? I think Dr. Merola is waiting, Clarisse, to start that conversation.
I know he is. Yes, so a little plug for my talk last week. If you have questions, I think that you are able to get to that. That talk specifically addressed this question in particular of what symptoms you would arrive at for DBS. So to be very clear, cognitive symptoms will not improve with DBS. And patients with advanced cognitive symptoms are not typically candidates for DBS because they can worsen. Now, all Parkinson's patients, it's a neurodegenerative disorder, so everyone has some thinking problems. Nobody's thinking is 100% perfect all of the time. So I don't want to frighten people off where they may think that they're not a good candidate for some reason of that. That's not true. But cognitive symptoms typically will not improve with DBS. And again, not something we would do. For DBS, we're thinking more of wearing off, medications not lasting long enough, maybe a mix of dyskinesia and the wiggles in wearing off, tremor that doesn't respond to medication, or maybe a dystonia, so muscle spasm that doesn't necessarily respond very well to medication. So those are kind of some of those reasons that might bring you to the main causes that might bring you to DBS. But again, DBS is more for motor symptoms and fluctuations. Now, that's not to be said that if when you're off, your thinking isn't very good or very clear. The goal of DBS is to give you more on time. So if you feel better when you're on, you could see some improvement then, but again, not a specific improvement that we would typically see from deep brain stimulation.
Actually, you're on mute.
I apologize. So we are getting to the end of our program, and we had one more question for Dr. Merola that came through our live audience today. Is wolfing down food part of impulsivity? Is food, and Dr. Boxley, if you had other clinical issues that come up with food in terms for Parkinson's disease?
Yes, impulsive binge eating can be one of the symptoms of impulsivity. So that is something that should be taken into consideration. Of course, we want to make sure, we know that, excessive eating and binge eating, it's a very complex disorder in which we don't want to, of course, blame Parkinson's disease or dopamine agonists for that. However, if there was a clear change in your diet after starting a Parkinson medication, that should be reported, and the Parkinson medication can be a cause for that. So you should probably try changing that medication.
I have just wanted to add, I have often heard from our patients that the biggest change they notice is that they never feel full after starting a dopamine agonist. So that is just an anecdotal thing that I have heard, but it's pretty popular. Just that they have to be more mindful to stop eating because they're not necessarily getting that feedback that they're full per se. So that's not really something we might treat, but just something to keep an eye on.
I would only additionally add that I think sometimes some changes in the types of things that patients are eating may cause a reduction in the type of whole foods that they're eating, the nutrients that they're getting. And we know that the nutritional value of someone's diet is important for cognition. How hydrated they are is important for cognition, and modifiable. So we could make sure they're having not just meals that are easily accessible, but meals that are also nutritious. That's going to help kind of reduce their risk of things like delirium and all of that, and just kind of keep their full body strength. So really paying close attention as providers as far as what is the person eating, what is the quality of what they're eating, and do they need assistance getting whole foods and adequate hydration.
Thank you. So we are at the end of our program. I want to thank again Dr. Merola, Clarisse, Dr. Boxley, Dr. Patel, and Melinda for joining us today to discuss this important topic, and to all of our attendees for your participation. We appreciate your feedback. As our program concludes, a window will open with a link to complete an evaluation of today's program, and we'll use these evaluations to plan our future programs. Today's program has been recorded and will be archived in the Parkinson's Foundation YouTube channel within a few days. A link to the recording will be sent to you via email in the upcoming days, along with a link to complete the program evaluation if you weren't able to do so today. It will also include slides from today's presentation and resources. The Parkinson's Foundation has been providing weekly educational wellness program in a virtual format through our PD Health at Home series. We invite you to participate in our PD Health at Home events, including Mindfulness Mondays, Wellness Wednesdays, and Fitness Fridays. Visit parkinson.org/pdhealth to learn more about upcoming events to register. We hope to see many of you in the Columbus area at the Moving Day Columbus on October 3rd, 2021. Please come out to help us support our mission and services. The Parkinson's Foundation is here for you. Please visit our website at www.parkinson.org to learn more about our expert care centers, research initiatives, or to download free educational resources. If you had any questions today that were not answered, please reach out to our free helpline at 1-800-4PD-INFO or email helpline@parkinson.org. You can also contact the helpline to order our free resources, including educational books and our hospital safety kit. Today's program was recorded and you will receive an email in the upcoming weeks with the recording and the slides. We thank all the speakers again, and we thank all of you for joining us. Have a wonderful day.